35-year-old female patient driver involved in an auto accident. She was rear-ended on the interstate. She's seen in the ER complaining of pain in her arm and neck. EMTs noted a compound fracture. So in the ER, she's treated for a displaced compound fracture of the shaft of the right radius and ulna, receives a collar for her cervical strain. So we have multiple injuries here that we're going to have to code, as well as those incident codes and external cause codes. So we're going to start with the fracture of the radius and a fracture of the ulna. Seventh character B is for that open type fracture. We also have a code for the cervical strain, and then we're going to start reporting those external cause codes. So the external cause here was that she was driving. She was a car occupant driver that collided with another car. The place of occurrence was a highway or interstate. So our rationale here, there is no combination code for fractures of the radius and the ulna, so we're going to have to code those each separately. Sixth character 1 indicates the laterality of that right arm, and the seventh character B was used for the initial encounter for an open fracture. And since the fracture Castillo classification was not listed, we're instructed to use seventh character B. You'll notice that we had quite a few placeholder X's throughout those codes in order to get those seventh characters in the correct spot. Our activity code is not assigned in this case because none of the codes add any additional detail. So the guidelines state that the activity codes are appropriate for use when the external cause codes for cause and intent if identifying the activity provides additional information. So in this case, we would only have a separate code for driving, which doesn't add to the definition we're already using for the patient was a driver of a car. This is a little different than when we were coding for the patient who fell off the ladder, where we're describing that they fell off the ladder while doing maintenance. Another example here, 10-year-old female seen for continued pain related to her elbow fracture. 6 weeks ago, the patient injured her elbow when she fell while skating at the roller rink. Further evaluation, the doctor found a non-union of the previously displaced right distal humerus fracture, and she's scheduled for surgery. So this is where we will go, and we will code that original fracture by site. And then the seventh character K there is for the non-union. We have an external cause code still. We're explaining that this patient fell while roller skating. And although the patient's being treated for a non-union, the external cause code would be added, but the seventh character D should be used to indicate that this was a subsequent encounter. This isn't an initial or a new fall. 50-year-old female who fell down the icy front steps of her single-family house has sustained trauma to her head as well as a non-displaced closed trimalleolar fracture of the I think that's what to say, medial and lateral malleus of her left leg. Patient denies any loss of consciousness. Attention was directed to her head injury, which, after CT, revealed a basilar skull fracture and small subdural hematoma. Neurosurgeon felt that the hematoma currently did not require surgical intervention. Serial CT showed shrinking of the hematoma after several days. So again, this patient's got multiple injuries, and we have the cause. So we're going to start with what would be considered the most severe injury, which would be the skull-base fracture. And again, that seventh character A for the initial encounter, along with the hematoma, initial encounter with the A. And then we have the fracture of the ankle there, the non-displaced fracture. We have the reason that this patient fell or got hurt was falling due to ice or snow from one level to another, so that's stairs or steps. We also have a code for where this happened. This happened at her single-family residence. And the last code is what that patient was doing. So Y99.8, other external cause status, so she was not working, not acting on behalf of the military. Again, once our payers start putting out more policies on which and when they want these codes, we'll have a little bit better idea if we really need to be coding this external cause status on every patient, or if it's really only for maybe government payers or patients on a workers' comp claim. There is no combination code for skull fractures with the hematoma. That's why we had to use 2 separate diagnosis codes. And in order to correctly code the skull fracture, those of us who aren't physicians would have to know the different areas of the skull in order to correctly code that. So that may be where, depending on the knowledge of your coding staff, because of the new terminology and more in-depth terminology in ICD-10, you just may have some questions on anatomy and physiology. And then again, our Y codes are coded to try to paint the picture of what the patient was doing and where they were doing it that led to the injury. Our last example we'll walk through today is our 22-year-old male who went to the ER after a motorcycle accident. He was wearing a helmet and did have a loss of consciousness. He has a displaced cervical C2 fracture with complete transection of the spinal cord. He has no feeling below his shoulders, but does have some tingling in his arms. No other apparent fractures. The physician's final diagnosis is stated as quadriplegia secondary to a C2 vertebral fracture with spinal cord injury. So, from a coding perspective, our coders would typically start by going to quadriplegia and trying to find a diagnosis there. And what they will most likely get is some guidance on where to code rather than at quadriplegia. And we'll be telling them to go code the fracture or cause of that paralysis. So we're going to start by coding that traumatic vertebral fracture. You'll see that 7th character A for our initial encounter. We're also separately going to have a code for the spinal cord injury. Obviously, you can have a fracture of the vertebra without having a spinal cord injury. Since we did, we're going to report that separately. Our 3rd diagnosis is going to be for that loss of consciousness. And then we're going to start reporting the codes on what caused this. So they were a transport motorcyclist driver collided with an animal. And then we're also going to code the place of occurrence, which was a street or highway, and that this patient was driving leisurely on their motorcycle. They weren't driving their motorcycle for work or as part of military action. So, fracture with spinal cord injury, we don't have combination codes there, so we're going to have 2 separate codes for that. S14, our code there, also stated that if there was any associated fracture, to code that as well. And then quadriplegia is not coded separately as it's the current episode of the injury. If you were to try to go look these codes up in the coding books, you would kind of be bounced around the index as it pushed you to and from the correct codes or codes that you need in order to build that out. So that's why for your coding staff, going through some of these exercises will be really helpful before go live, just to get familiar for some of the differences in how we code for injuries. Our activity code is not assigned similar to the car accident or riding a bicycle. It's implied that if you're on a motorcycle as the driver, that you are driving, and that's what you were doing when the accident occurred. We don't have to further define that. Unlike if you fall or trip, we might be defining what you were doing when that happened, like rollerblading or walking or running. And with that, we will be concluding tonight's presentation. I'd like to thank you all for attending. And if you have any questions, I'll turn it back over to Stephanie to start those.
Thank you. Let me see. It looks like at this time there are no questions. I can give everyone just a moment if you want to type your question in. Okay, it looks like we have no questions this evening. Thank you everyone for attending this evening's ICD-10 webinar on fracture provider services. And Regan, thank you for your presentation.